everyone. I'm Aubrey Rhodes. I have the privilege of serving as the executive director for LCRF. And our mission here at LCRF is to fund research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. Today, we're going to be covering really a wide range of topics on the latest in research and information that came out at the recent World Lung Conference. But before we get started, I just want to share with everyone. So this is our last regularly scheduled together separately for 2024, but we will have an opportunity for everyone to gather on November 4th. We'll be hosting our annual scientific meeting. So there'll be a state of lung cancer research. We'll have some roundtable discussions around areas of unmet need in the research space. So we certainly hope you all will join us for that event. It should be really nice. And we've got some really special speakers that'll be joining us. Additionally, I want to invite everybody to our Free to Breathe walks, which are coming up in the next couple of weeks. It's a really great opportunity to kind of rally and create awareness and visibility for lung cancer out in the community, and raising some funds to really move the needle in research. So we hope you all will join us as a part of that. I think they're going to put a couple of links in the chat so that for anyone that's interested, they can find a little more information. I will also just say, just a reminder, we ask that everyone stays on mute throughout the call. The chat, however, is open. So feel free to chat any of your questions, comments, thoughts, right in there. We will have the captions enabled, both for English and Spanish. There is the option to turn those off if you'd like. Other than that, it's really my pleasure to introduce our moderator for today, Dr. Isabel Preeshagul, who also sits as the chair of LCRF's Education and Engagement Committee. She's an assistant attending on the thoracic oncology for Memorial Sloan Kettering Cancer Center, and we're so glad to have you here with us today. Thank you, Is, for moderating today's discussion.
Thank you very much, Aubrey, for the very kind introduction. I am so excited to be here, joined by two outstanding physicians that I have the pleasure of introducing to you, even though I'm sure you know them both very well and they don't need much of an introduction. So our first guest that we have today is Dr. Jyoti Patel, and she is a professor of medicine at Northwestern University and an associate vice chair for clinical research in the Department of Medicine. She is also the medical director of the thoracic oncology and assistant director of clinical research at the Lurie Cancer Center. Dr. Patel is clearly a leader in thoracic oncology, focusing her efforts in the development and the evaluation of novel molecular markers and therapeutics in patients battling non-small cell lung cancer. So, Dr. Patel, welcome.
Thanks so much for a kind introduction.
Of course. And our second guest is Dr. Lyudmila Bazhenova, and she is a board-certified medical oncologist at the Moores Cancer Center of UC San Diego. Her clinical practice is devoted to patients with all types of lung cancer, and she has particular expertise in patients that are female with no smoking history. She believes in a multidisciplinary approach to patients with lung cancer and works very closely as a multidisciplinary team with the surgical oncologist and radiation oncologist to provide the best patient care possible. We are so honored to have you both, and I know you both also sit as very essential members of the Education and Engagement Committee, so I thank you for your efforts there as well. And I am thrilled to get this discussion going, where we are going to be reviewing the latest practice-changing data in regards to those that attended the meeting. World Conference of Lung Cancer is a meeting that happens, it's an international meeting. Sometimes it happens in San Diego, sometimes it's in Europe, sometimes it's in Asia. But basically, it's a way to have a meeting of the minds. There's thoracic oncologists there, radiation oncologists, surgeons, pathologists, students, fellows, residents. You know, it's a very empowering meeting where we all get together and we discuss, you know, updates that have happened since ASCO, but before ESMO. So it's kind of like this interesting time period where there might have been data that was touched upon at ASCO, but they say hear more at World Lung. So we're going to be talking about some of the data that was presented at this meeting called World Conference of Lung Cancer. We're going to talk about targeted therapy. We're going to talk about the early stage setting, and some small cell data and also some newer therapeutics. So bear with us and please feel free to put questions in the chat. I'll keep my eye on that as we go forward. So we are going to start with Dr. Bazhenova, who is also known as Luda. And we will start with her. And the first topic that we are going to talk about is data from our Harmony 2 trial. Luda, do you want to tell us a little bit about what this study was looking at and what some of the goals were and the endpoints of this study?
Sure. So this study called Harmony 2 looked at the new drug, which is called ivonescimab. And this is what we call the bispecific antibody. So it's an antibody that attaches two separate receptors. One of them is a PD-L1 receptor that should be familiar with you because that's our approved immunotherapy drugs that attach to the PD-L1 receptor. And the second is a VEGF receptor. And we also have a monoclonal antibody already approved for the VEGF, which is bevacizumab. And what that drug does, it just physically connects to those receptors together. And when those two receptors are connected, we think that it changes the way immune system reacts to cancer. And the study took patients who did not have an oncogenic driver, so they had to be EGFR ALK negative. The patients were newly diagnosed, so did not have any prior treatment. They had to have a PD-L1, so that protein expression more than one, and the patients were randomly assigned between standard of care, which would be pembrolizumab, versus instead of pembrolizumab, they basically give the ivonescimab. And the way you think about ivonescimab, it's like pembrolizumab plus bevacizumab in the same molecule. And the study was positive. So it's showing that the new drug, the ivonescimab, improved the chance of the cancer shrinking. It also delayed the time for the cancer regrowth. And the benefit was seen in both adenocarcinoma and squamous cell carcinoma. They saw a slight increase in adverse events, mainly due to the VEGF inhibition, such as hypertension and proteinuria. But otherwise, the study was very positive.
So I appreciate that very simplified version of what this study is so that we are able to digest it in bite-sized amounts. And I think always having another agent in this setting is very helpful. Is there somebody that you would think of for ivonescimab instead of pembrolizumab in this setting? And how would you choose, how would you decide what you would offer for your patient?
Yeah, so right now there are a couple of problems with that study. So number one, this is not yet available in the United States. The study was done primarily in China. And there are differences in how different populations metabolize the drugs. So we really cannot accept the China-only study and assume that it's going to have the same benefit in the United States. So the company is running a similar study in the United States. And for those of you who are interested, certainly look up where the sites are and then consider participating. Right now, if the study that's going to be run in the US confirms the finding of an Asian study, I think to me, it would be a very easy decision for patients who have a PD-L1 more than 50. So when we look at our patients who do not have oncogenic driver, we look at something that's called the PD-L1 expression. And we separate all the patients in three groups: PD-L1 less than 1, PD-L1 1 to 49, which is a percent of the cancer cells that have that protein on their surface, and PD-L1 more than 50. So for the PD-L1 more than 50, my standard of care is either pembrolizumab or pembrolizumab plus chemo. So for me, this is kind of, in my opinion, is a no-brainer to consider ivonescimab over pembrolizumab. The 1 to 49 group is more complicated because I do not think pembrolizumab is the correct answer for 1 to 49 because I think for those patients, chemotherapy plus immunotherapy is the best option. So at this point, without having a clinical trial comparing ivonescimab to a chemoimmunotherapy, I don't think I would be offering that drug to patients who have PD-L1 expression 1 to 49.
So just to comment, you know, certainly this was a really positive trial and brings together so many, I think, unanswered questions. For over 25 years, we've been talking about angiogenesis inhibitors in cancer, and we've had approval of antibodies that block VEGF, and they've shown to improve survival in lung cancer as well as other cancers. So the drug bevacizumab, for example, is still approved in combination with chemotherapy. Many of those have kind of fallen out of favor as immunotherapies have become a standard of care. But there's a lot of data about how these drugs how targeting both of these pathways together may work. So it may be that VEGF inhibition may change the immune microenvironment and make immunotherapies more potent. So that's an area that's been tested with two separate drugs. How cool would it be if it was all on just one drug? And we think bispecifics kind of amp up the immune response. And then in general, these immunotherapies, we think, you know, improve outcomes certainly, or excuse me, these anti-VEGF drugs improve outcomes with chemotherapy. They've been tested certainly in the EGFR space, so not with immune therapy, but I see a question in the chat about ramucirumab. So that's a trial that was presented with osimertinib last year, and it was a positive trial in terms of progression-free survival. We don't have overall survival. But so this is a class of drugs that we have been excited about for a long time. If we can harmonize both immune therapy and VEGF therapy, I think that's a huge leap forward if we can replicate this study in the US. Sorry to jump in, Luda.
That's okay. Always good to have another view.
I agree with both of you. And I think, you know, we are very fortunate to have this study open at Memorial. And I think what I'm looking for or trying to identify is a signal of, let's say you have someone, you know, with a high PD-1, you know, that's rather fit. Obviously, we always offer a trial for these patients, but I'm wondering if there's a signal. Is it because the addition of the VEGF inhibitor aspect, you know, may help patients that have CNS metastases? Is this something that, like, if they have peritoneal disease, perhaps this is an option for them? And I'm trying to just kind of tease out to see if either of you got a sense from reviewing the data of Harmony 2 that maybe there would be a preferred patient for this regimen.
I don't think we know yet if there's a preferred patient for this regimen. I think I'm looking at the presentation. I don't think they've shown any kind of specific subset of patients where the drug is more effective. Yeah, so they did not, I'm looking at the presentation again, they didn't show any subgroup analysis besides PD-L1 expression as well as histology. So it's a good question, but like, what if, let's say, you know, so there's something about history, smoking history, or some other things that will show that one, you know, the population of patients is more important or not. So at this point, we don't have that data from this trial.
I agree. And it's just something I'm searching for. So I'm hoping, you know, maybe at our next meeting, we'll be able to identify who would benefit from this. But as of right now, I think if you are on this call or you know someone with newly diagnosed advanced disease with, at least for now, with a high PD-L1 expression, meaning greater than 50%, I would advocate for yourself to see if this protocol is open where you're being treated, or if you can be seen at an institution that has this protocol, because it could potentially be better than single agent pembro. We don't know yet. So I think stay tuned. But let's move on in this space about two other new agents. One is zongertinib, and one is BAY or BAY 2927088. And these were two exciting studies that were presented at the Presidential Symposium in regards to the treatment of patients who harbor HER2 alterations. So we're shifting away from the immunotherapy space to HER2. And very curious, Luda, about what your thoughts are on these two studies and the, you know, the overall response rate for both of them, and how you would, how you view the data in this up and coming space.
Yes, those two presentations actually got my gold medal. I think for me, that was the most exciting presentation of the world long. And now, as you correctly, as you stated, we are moving away from the all comers and going to a very rare patient population with lung cancer, patients who have mutation in a gene called HER2. And that happens in approximately 2 to 4% of the patients. You have to do molecular testing, ideally with a next generation sequencing, to see if you have that mutation or not. Currently, our standard of care for patients with that mutation is chemotherapy first line, wait until it stops working, and then you go to the antibody drug conjugate called trastuzumab deruxtecan, and that has shown very good response rate of approximately 55%. But unfortunately, trastuzumab deruxtecan does come with side effects. It's still, even though it's an antibody drug conjugate, but it's still a chemotherapy. So all the chemotherapy side effects are certainly going to be there. So we always were excited or looking for a treatment for our patients, which is a little bit easier. So something that's called a tyrosine kinase inhibitor, which is a pill similar to what we are aware, like osimertinib or alectinib or lorlatinib or repotrectinib, some kind of pill that we already have for other patients with oncogenic drivers. So two compounds were presented at World Lung. This wasn't the first ever presentation for those compounds. Both of them were presented at ASCO and at ESMO last year. So we already knew that the medication has efficacy. The good part about the presentation at the World Lung is we now have a bigger patient population. So we have more confidence that this is indeed something that could potentially become an approved drug. So the first I'll start with zongertinib. So the study name is a BEAMION Lung 01, and it gave the drug to the patients who have a HER2 mutation and have received in the past chemotherapy. And it showed that 70% of the patients had shrinkage of the cancer. And 70% is actually a pretty good number in our patients with lung cancer, and that we would expect for the good tyrosine kinase inhibitor. The toxicity profile for the zongertinib was actually pretty good. They did see diarrhea and rash being the most common side effects, and majority of those symptoms were low severity. They were grade 1 and grade 2. And then the BA2927088, it's a very similar drug, but different pharmaceutical company that makes it. And they also updated their data for the same patient population, showing overall response rate is also approximately 70%. Here, they also were able to report time to progression, which is 7.5 months. And toxicity profile was actually also very good, mainly diarrhea and rash. So at this point, I'm very excited about those medication. Of course, the company needs to have more trials. Eventually, I hope that they're going to do the trial in a newly diagnosed patients, because I certainly think this is going to overtake chemotherapy in that space based on the just side effects as well as response rates. So very exciting for me.
Yeah, I totally agree. And I'm so happy to see that we have other agents. At first HER2, patients that harbored HER2 alterations, it was kind of this orphan group, and we didn't really know what to do with them. And now, this space has really become, front and center, which I'm excited to see, and having more options outside of trastuzumab deruxtecan and T-DM1 trastuzumab on study is very exciting. And I think, seeing the overall response rate of around 70% and the disease control rate of around 95% for patients on zongertinib is very exciting. Also, you mentioned that the toxicity profile is far, is I can't say far better tolerated, but it's not as significant from what we can see. And I think some of that comes from the fact that we're sparing the EGFR side effects with this drug. What were your thoughts about some of the intracranial responses that we saw?
I think always, brain is what I call it a battleground. So brain is important for durability of our responses. So I think I don't remember if they presented intracranial responses on that presentation. I think they did. Um, Usually, I can look it up, but usually brain responses are always welcome because that increases durability of the drug.
Yeah, I think it was mentioned in passing. It wasn't outright presented, but I'm always intrigued by that because we know that the CNS space tends to be this sort of sanctuary site where we can't find drugs that penetrate through the blood-brain barrier. And historically speaking, TDM1 and TDXD are just not great at doing this. So maybe we have a signal here, and maybe this might help guide us who would be an appropriate candidate for this drug in the future. So moving on in the HER2 space, we can move on to the second drug that we wanted to talk about. And I would love to hear what your thoughts are about this, and maybe we can kind of compare and contrast some of the toxicity that we saw with Bay as opposed to Dongertinib, because I know it seemed that there was a little bit more maybe toxicity with Bay, to my understanding.
It's always hard to answer the question because you are now comparing cross trials, right? So, and there could be different patient population, different anything. So I numerically, when you look at the Bay toxicity, numerically, there is a little bit more diarrhea and a little bit more rash and maybe a little bit more of a more severe diarrhea. But it's hard for me to say that one is better tolerated than another without a head-to-head trial and B, personal experience with the drugs. Both of them, in my opinion, are still going to be better tolerated than trastuzumab deruxtecan.
Yes, I totally agree. And tell us a little bit about what some of your thoughts were in regards to the base study.
So it's basically very similar. Took the same patient population and showed overall response rate of also about 70% and progression-free survival of about 7.5 months. So it's again, if you look at the efficacy data, it's very, very similar. The one thing that the Bake presentation did is they separated the HER2 mutation into the VMA mutation and non-Y VMA mutation. But I think at this point, it's really, I'm going to make the decision regardless of the VMA or not. YVMA is the most common mutation in HER2 that tend to respond better to anything we give it. And so in Bay trial, they also see higher responses in YVMA versus non-YVMA, but it's not going to change. Again, I'm going to give it regardless of the type of mutation as long as it's a HER2 insertion, exon 20 insertion mutation.
Yes, I definitely hear that. And I learned so much from this presentation because typically we're not really looking for this YVMA alteration within HER2. And now that the data shows that maybe there was a little bit of a better response rate for those that had this sort of subset under HER2, that there might be a signal, but I agree. I would give it regardless.
But for me, I'll say you got me at hello. I was happy with 70%. I did not need 90%. So that's why it's like, it's cool. But, even if they didn't show that, I'm already impressed.
Yeah. Yeah. And I did see, just like, I know we're not supposed to do cross trial comparisons, but because these two were both presented and within the same space, it did seem like maybe the Bay drug had a little bit more diarrhea, a little more GI toxicity than Zongertinib, but I'm not sure if you got that sense as well.
That's kind of, let's say, numerically the numbers are a little bit more diarrhea. Actually, overall the diarrhea is the same. I'm looking at the presentation right now, but the grade 3 diarrhea is a little bit more in the Bay compound. But it's really hard to compare them because we are talking a very small number of patients. For the Bain 292, there was only 44 patients enrolled. So one patient gets grade 3 diarrhea, it completely screws up or changes your frequencies. So at this point, I wouldn't be comfortable saying that one drug has worse toxicity than others.
Okay. And I see a question in the chat, and I know there have been other questions that we will definitely get to at the end once we go through the data, but excellent questions. But there's a question about CNS penetration with Bay versus zongertinib. I don't think we have that exact data, but go ahead, Ludo.
Yeah, have not been reported yet. So, and I even looked at the prior presentation of zongertinib. They did not report CNS efficacy, and neither did they report the CNS efficacy in this presentation. And I don't think they even commented on the restrictions for the patients with CNS metastasis if they were allowed in. For the BA292, in the ongoing SOHO-01 study, they actually have a special cohort specifically looking for patients with active brain metastasis. So they will have the data, but at this point, it has not yet been presented. Kind of thinking about the class of drugs like that, so the tyrosine kinase inhibitors in general have activity in the CNS, but I just cannot give you the percentages or numbers because they have not been reported yet to us.
Yes, but I think, you know, I would definitely stay tuned for that because I think that data is coming and they were hinting at it during the presentation. So I think you hit the nail on the head that that's the next thing that we're waiting on. If there aren't any more comments about the HER2 space, I think we can sort of shift gears a little bit. Yet again, oh, we have one more quick comment about trastuzumab deruxtecan and CNS penetration, and it's not fantastic, to be honest. And typically for patients that have HER2 alterations that have CNS metastases, I'm very quick to refer to radiation oncology, especially if they're symptomatic, because we know that these antibody drug conjugates targeting HER2 typically don't have great penetration. But curious about you, Jyoti, and you, Ludo, what your experience is and your thoughts on TDXD and CNS penetration.
So certainly I think there's variable penetration. I've had some patients with good response, and we know from the breast literature that there is some response, but you're right. Often I am limited in terms of toxicity or just getting a response quickly. And so radiation certainly has a role. But I have not seen CNS's first site of relapse on trastuzumab deruxtecan. Luda, yourself?
Yeah, me neither. I haven't seen a CNS as a first site of relapse. And then the data for the Destiny Lung shows some actually response rates. They say 50% response rate if you look the RECIST, and about 86% of decrease in tumor size. So it appears to have an activity. And so if I have a patient with HER2 who I'm considering trastuzumab deruxtecan, and they have a small asymptomatic brain mets, I'm actually no longer radiating that. I'm trying trastuzumab deruxtecan first before I consider radiation.
I might just be unlucky, I guess. But that's good to hear, and I hope that answers your question. But for now, we are going to sort of shift our focus a little bit away from the advanced metastatic setting to more of the neoadjuvant or induction or early phase setting. There was some very exciting data that was presented when looking at Checkmate 77T and Checkmate 816, which were Checkmate 816 was the first study that was approved in this space, was basically giving patients chemotherapy and immunotherapy before they go on to surgery. And there was wonderful data exploring major pathologic response and complete pathologic response for these patients, and basically looking at how much of the tumor after they got 3 cycles of chemo and immunotherapy and had surgery, how much of the tumor is dead when it's taken out, is basically a way that we measure efficacy of these neoadjuvant or induction studies. Jyoti, let's talk a little bit about Checkmate 77T and Checkmate 816, and if you could sort of compare and contrast them and sort of break it down for everyone as to the differences between these two studies.
Sure. So the neoadjuvant approach is just that we are treating before surgery. We love neoadjuvant studies because we can see the cancer shrink. We know that something's going to be efficacious on CT scans, and then we get information afterwards and can make decisions about surgery. And that is really what 816 looked like. It was 3 cycles of chemotherapy with immunotherapy nivolumab. The sandwich approach or perioperative approach, whatever you want to call it, is giving immunotherapy both before and after surgical resection. So it's got the neoadjuvant piece. Theoretically, that sort of primes your own immune system. There's been antigen release. You're able to develop a T-cell repertoire that recognizes the antigen as more effective than just giving immunotherapy afterwards, but you give chemotherapy and immunotherapy before surgery, and then regardless of response, if the person has a complete resection, you go on to further immunotherapy. And so these are 2 strategies that have been approved with different drugs around the world. And then the last strategy is just adjuvant therapy when someone has surgery and then gets immunotherapy afterwards. And by then, kind of all your cards, like exactly what the tumor is, but you really don't get an in vivo assessment of whether the drugs that you're giving are working. So multiple trials have been done in this space. Hundreds or thousands of patients have volunteered to be on these studies. And we have a bunch of things that we can choose from. Unfortunately, none of these studies have been compared head-to-head, or strategies have been compared head-to-head. And although we get frustrated about it, I think we all have to recognize that this space has evolved so quickly. We've been able to go from assessing pathologic complete response to clinical practice within just a couple of years, whereas often these trials would have taken like a decade to do properly to get all of the answers. And so one thing that we are doing, instead of doing a head-to-head comparison, like the ideal trial would be like, okay, let's compare 816 to 77T and see how patients do and see who fares better. But that answer will likely take years. And so we're always looking to see if there are ways that we can assess the data to draw inferences. And that's great. This is the most robust kind of study that you can do, which is what Patrick Ford and the BMS group did, was like, let's look at individual data and compare it and then try to make some generalizations. That kind of statistical analysis is great. It's thought-provoking, but there are a lot of issues with it because you're not looking at the intent to treat population. So all people that would have been randomized. You're only looking at subsets of patients who did well enough after surgery to get an additional dose. And so for the statisticians who might be listening, like, I get that it's not ideal, but certainly this gives us more data than we've had traditionally. And so what this group did was they looked at individual patient data, and they looked at 816, all the people who completed surgery, and the patients from 77T who had at least 1 dose of nivolumab after surgery. So of all of those patients, they ended up looking at about 300 patients between both of the studies. And so what we know is that anyone who got perioperative nivolumab, that was super effective. It reduced the risk of recurrence by almost 40%, so substantial. And so that is certainly a standard of care. But when we get into the analysis, what we find is that probably giving more nivolumab after surgery is beneficial to patients who don't have this thing we call pathologic complete response. So about 1/4 of patients across all trials develop pathologic complete response to immunotherapy. So that means that when we take the tumor out, we don't see any evidence of disease. And so those patients we've seen on a number of trials, they seem to have pretty similar event-free survival, whether you do just the induction approach or neoadjuvant approach versus sandwich approach. But patients who don't, the vast majority of patients, 75% of patients, there's probably some benefit to doing more immunotherapy or more nivolumab from 77T afterwards. The other group was also, if you tease out by PDL expression, so they did PDL positive versus PDL negative, and probably more immunotherapy was was beneficial in patients who were PD-L1 negative. It's a small group of people and we need some longer follow-up, but it may be that giving a little bit more immunotherapy in these patients might be beneficial. We know that if we take sort of all comers, probably perioperative nivolumab numerically looked a little bit better. So this is certainly thought-provoking. We need to look at it prospectively. There are a number of ways that I think we can move forward with this. So certainly a trial in which which is being planned and being done in our cooperative group system in the United States, or will be done, looking at, okay, what's the depth of response? Can we de-escalate immunotherapy? So if you have path response, do you need additional immunotherapy? Another way that many of us are really eager to understand is, are there blood tests? Are there assays looking for minimal residual disease that may guide our treatment? So this is a rapidly evolving space, but certainly this data and the data across a number of trials have kind of helped me talk about what to do with patients in clinic. So if you get immunotherapy and chemotherapy and have a pathologic response, with no evidence of disease, I think it's absolutely reasonable to sort of de-escalate and not do additional therapy. Again, that's based on inference. It's based on one trial, 816. But for patients who don't have a pathologic complete response in practice, I've been talking about doing further immunotherapy and ongoing immunotherapy that lengthens the treatment up to another year of therapy. But this sort of gives me more confidence in that.
That is so helpful, and thank you for giving your perspective on such a complicated, ever-evolving space. And if you were to survey 10 thoracic oncologists in the room, I guarantee you'd have 10 different answers. And people are interpreting the data very differently. I've had, there are some people that are of school of thought that if your resected tissue doesn't show major pathologic response after 3 cycles of induction chemo IO, what is the role to give you more, right? If you didn't respond initially. But then I also see the point of, if you had, if maybe that wasn't enough, right? If you still have some angry tumor left, maybe you just needed a little more, and that's what does it for you. So I still don't know, and I like wax and wane with all my patients in clinic about this decision exactly. Luda, how do you handle patients that are in this clinical scenario?
I'm struggling with that, to be honest with you, and I have a slightly different opinion. I kind of say, until you show me in a randomized prospective clinical trial that I should de-escalate, meaning not giving immunotherapy if you are in past CR, I didn't take that Patrick Ford presentation as a call to action that I should stop immunotherapy for the past CR. So right now I am a believer in sandwich therapy, so before and after. And at this point, I am considering I'm giving immunotherapy after. It's just, I don't know. It's kind of like, in order for me to give up something, I have to give a good evidence, versus when I add something, then to me, I kind of need a little bit less. But it's like, as you said, Isabel, if you ask 10 people, you are going to have, probably 50-50 answers in that patient population.
We actually had a debate at World Lung, right? And so I was on team neoadjuvant. There was a sandwich team and an adjuvant team. I think the sandwich team, like, they brought props. So they brought sandwiches that were open to try to get the audience there. But certainly, I think as on the adjuvant team, or excuse me, on the neoadjuvant team, one thing I said, and as you brought this up, was like, what's the definition of insanity? Doing something that doesn't work, like, to keep doing it, right? Like, so that's give more immunotherapy when it's not effective. And that other piece, Luda, that you talk about, like, you never want to feel like you're undertreating a patient. And we don't understand long-term tox yet either, right? In terms of heart disease, in terms of cognitive function over time. And so we got to study this prospectively.
Yep.
Yeah, I think it's really all about a discussion with your patient is what it comes down to, because they're the one that's going to have to be coming in, every 4 weeks for treatment, ongoing for a year, and that impacts their quality of life. right? They have to come once a month, and that's a lot. That's when they could be done technically. So more to come. So in that same breath, there was another very exciting trial that was presented at the presidential symposium at World Lung, NeoCOAST 2. And we're moving a little bit away from the regimen that was offered in the Checkmate regimen. Here we're looking at combining antibody drug conjugates with immunotherapy. So, Jyoti, can you tell us a little bit about your thoughts about NeoCOAST 2 and like the arms and how this study was designed?
Sure. So NeoCOAST uses a different immunotherapy, durvalumab, that's been approved for in small cell first, and after chemoradiation in non-small cell and small cell as well. And so it's a drug that we are all really comfortable with. There was a trial called Aegean, which is also perioperative therapy, and NeoCOAST, not NeoCOAST 2, like version 1.0, kind of builds upon this. So it looks at durvalumab with chemotherapy and novel agents. And generally, again, it's as neoadjuvant and adjuvant therapy. It's a phase 2 trial. So the primary endpoint is path CR rather than event-free survival or overall survival, because we don't have really statistical confidence on that. So the investigators, Dr. Casconi, reported 3 of the arms, or multiple arms. And one was with neoadjuvant durvalumab and platinum chemotherapy, so standard, with an antibody against CD73 or olasluumab. So that was one arm. Another arm was durvalumab chemotherapy and an immune checkpoint inhibitor that targets NK cells, so monalizumab. And then finally, another arm with durvalumab chemotherapy and Dato-DXd, and that's an antibody drug conjugate that targets TROP2. It's a protein that's expressed on the vast majority of lung cancer cells. So these are the 3 arms with different combinations. So 2 of them had 2 checkpoint inhibitors, one with an antibody drug conjugate. So we've all had our eye on Dato-DXd. We've seen it in as monotherapy in the second line setting. We've seen it with carboplatin and durvalumab in the frontline setting. So now looking at it in the resectable setting. The path complete response rates on these different arms were somewhere between 20 and 35%. And that's kind of what our expectation would be. It's what we've seen with immunotherapy and chemotherapy. But really the highest one was combining durvalumab chemotherapy and Dato-DXd, and that path CR rate was about 34%. Moreover, the major pathologic complete response rate, so that's when you have less than 10% residual tumor, was like 66%. So it's really effective. Now, these antibody drug conjugates, we kind of think of them, you heard a little bit about trastuzumab deruxtecan, but we kind of think of them as like a smart bomb, like we're directing a very potent chemotherapy to the cancer. And so we think that intellectually, we feel like it should be really more cytotoxic, so that we should see more cancer killing. And that's certainly what we saw in this regimen. So there is certainly interest in developing these regimens. I think next steps are really going to be looking at which patients need the additional therapy, right? A quarter of patients do really well with immunotherapy and chemotherapy. Who needs the additional toxicity of one more drug? And there are risks with some of these drugs. You heard us talk about things like interstitial lung disease. Again, we worry about over-treating patients in the long run. And so developing the biomarkers that would be appropriate for patients, I think, is really our next task.
Yeah, exactly. And I think we're learning more and more that, I think we knew initially PD-L1 is not the end-all be-all biomarker if patients respond, because even in looking at the NeoCOAST data, I think there was 25% path CR in patients that were PD-L1 negative, which also kind of makes you scratch your head like, well, why is that? Was it the antibody drug conjugate? Was it the IO? Was it the combo? What? right? I don't know. What did you think of that?
Exactly, right. So that might be how we enrich patient populations. And I guess one piece is also just some caution in that um, a lot of these trials are smallish. And what Luda was saying before, like you may have a couple of patients with a great response, and that really changes your assumptions pretty significantly. So probably more to come.
Yeah. Luda, any closing remarks or thoughts on Meal Coast?
Actually was excited about it. I think when I was listening to the presentation, I had the same kind of impression as Jyoti. I was like, oh, that looks pretty interesting. So, and I think we also like when we see in cancer therapy, when we see something interesting, my second question is like, is there a reason why it's interesting? And I think here I see the reason why it actually could be interesting. As Jyoti said, maybe more direct delivery of the chemotherapy, maybe something they kind of interact with immunotherapy and maybe more neoantigen release, and then immunotherapy gets more effective. So I was definitely noticing that presentation when I was sitting there listening.
Definitely. So this discussion is a perfect segue to talk about the use of antibody drug conjugates in back to the stage 4 setting. So just kind of shift everyone's gears again away from induction neoadjuvant back to stage 4. I really want to explore looking at, TROP2 as a marker, as you had commented. I know this is a marker that's on the outside of many patients who have non-small cell lung cancer. It carries a poor prognosis. It's something that we're just starting to learn to look for in these patients. And there was quite a bit of buzz about this marker at World Lung, and most specifically surrounding the TROPION-Lung01 study. Could you tell us a little bit about this, Jyoti, and what your thoughts were about this data?
Sure. So as you said, we've been excited about TROP2 for a long time, and we gained some of our excitement from also other cancers, right? Like urothelial cancer, breast cancer, that TROP2 antibodies have outperformed chemotherapy. And we're hoping that's the case in lung cancer. So Tropion Lung 1 is a trial that we'd heard about at ASCO, and then we're getting more information. So it's a phase 3 trial that compared Dato-DXd. So that's a TROP2 antibody. And when we're thinking about an antibody drug conjugate, we talk about the antibody, the linker, and then the payload. And the antibody is what hits the protein that's expressed on the cancer cells. When it hits that, it's got to unlink, and that's sort of the linker, and then the payload has to deliver wherever the drug is bound. We thought before that those were very specific just for the cancer that the payload was internalized into the cancer cell. We think now that there's probably a little bit of activity in the environment, so cells next to it may also have some death. And so this is an area that we've been exploring for a long time. There's like 120 antibody drug conjugates that are in development, and we're trying to understand how to bring these really potent payloads to patients. So anyway, TROP2 looked at Dato-DXd. So this is a drug that has been developed for some time versus the standard second line option, which is docetaxel. So we know that after chemoimmunotherapy for patients with who don't have an actionable genomic driver, that docetaxel is a drug that's efficacious and works and can be effective in some patients. And we knew that from the previous iteration that the time until the cancer grew, the progression-free survival was improved on Dato-DXd versus docetaxel. And we'd kind of gotten our heads around some of the toxicity. But unfortunately, we learned that this study didn't meet its overall survival endpoint. So in patients who received Dato-DXd, the overall survival was just shy of 13 months. And then it was just shy of 12 months with docetaxel. And then we had seen in the earlier presentation that probably histology mattered. I don't think when the trial was developed, we thought there was a real difference between people with non-squamous tumors and squamous tumors, but certainly we start to see really where the curves kind of separate. And so in patients with non-squamous tumors, the majority of lung cancer, the median survival with Dato-DXd was like 14 and a half months compared with 12.3 months in docetaxel. And this was numerically better. It represents a significant decrease, or it represents a decrease in death, but it didn't really reach statistical significance. Numbers were small again. Moreover, this is certainly attractive. We also know that there are fewer side effects with Dato-DXd than with docetaxel. They're different side effects, but fewer. So like 26% versus 42% for those grade 3 toxicities. There was a subset of patients who had actionable genomic alteration. So that means like EGFR and ALK. And for those patients, the median overall survival was kind of the best. It was like 15 and a half months with Dato-DXd versus just under 9 months with docetaxel. And so, there's certainly interest in this, sort of reading the tea leaves. I don't think this is going to move forward in squamous cell, probably in non-squamous. And again, these numbers are close, but certainly we're hoping that this will be an option for our patients in the future, hopefully not too distant future.
Yeah, I agree with your tea leaf read. And I think, I think that we are always looking for options for patients that progress on Keynote 189. And I don't think we still don't know what the right answer is for these patients. So having more options, I think, is very exciting and something that I always look for. And I think if you're a patient that's on the line, or you're an advocate, or you have a family member, I really encourage you to ask your oncologist to send your tissue, your initial tissue, for staining to see if an antibody drug conjugate might be worthwhile for you. Outside of Tropion-Lung01 and Dato-DXd, we have we have trials that are looking at patients that could receive antibody drug conjugates for overexpression of HER2 and overexpression of MET. So I'm starting to ask our pathologists to stain these tissues for HER2 and MET immunohistochemistry, or MET IHC, or HER2 IHC, because these drugs, we have studies looking at giving MET antibody drug conjugates and HER2 antibody drug conjugates for patients that have overexpression of MET and HER2. So please advocate and ask about antibody drug conjugates and if there's a role for them in your treatment plan.
Yeah, and I think also with TROP2, I don't know what FDA is gonna do, right? So this is the trial is negative. It's a subset analysis which is positive, and the trial had dual primary endpoint, PFS and OS, and only one primary endpoint was met. The second one wasn't. So I'm kind of on my edge of my chair to see what the decision of the regulatory authorities is going to be. But I think what another presentation at the World Lung that I actually found very exciting was to maybe look for a better biomarker for the TROP2. So we know when that Dato-DXd was developed, they actually looked at the expression of TROP2 and its ability to predict efficacy of the drug, and there was no ability. Majority of the lung cancer cells do express TROP2. So it wasn't predictable. But in this World Lung, Dr. Garasina presented a new biomarker that's not yet available to all of us commercially, but it basically looking at the composite biomarker measuring the surface expression of a TROP2 and the cytoplasmic expression of TROP2. And they found out that if the patient is that biomarker positive, the outcomes are better. And so I think I would love to see the overall survival data based on that biomarker. And then we'll have to figure out like how to scale that biomarker, because it's not a simple thing to do. It requires some advanced pathology. But I'm excited about this development at World Lung as well.
It's pretty cool. They're using sort of a pathologist trained deep learning algorithm, right? So it's really computational, which is exciting. That means that it's also scalable, that you can just, that it's not a single pathologist learning to CLIA certify it and do it in your own lab, that hopefully we can implement this if it passes, and get it to our patients quickly.
Exactly. I was also very intrigued by that. And I'm so glad that you brought that up, Luda, because I think, we kind of get set in our ways, and there's all this buzz about trope 2, but maybe that's not the right signal. And I think we need to cast a wide net and keep our eyes open. There's over 300 antibody drug conjugates that are in development right now, and I don't think we know what to do with these drugs. We don't know if this is sort of a passing wave, or if this is the new thing. So very excited. So I think, in regards to the interest of time, I know we have a lot of exciting questions in the chat that I want to get to, but let's go forward with a little bit more of the data. So we have, moving on to sort of the targeted space here, there was a lot of data presented for patients that harbor EGFR alterations, and this has become practice changing, and it's already sort of changed my discussions that I have with patients in clinic. 2 weeks ago, you progressed on osimertinib, and we were talking about, clinical trial or chemo, and now you've progressed on osimertinib, and here we are, we have all these other options, or newly diagnosed patients with stage 4 non-small cell harboring an EGFR mutation. We have all these other options. So this has become such a complicated, space to navigate. So I really want to focus on talking about Mariposa and Mariposa 2, but obviously if this discussion gets, a little bit more, broad, I'm okay with that too. But let's first talk about Mariposa a little bit and where this fits in sequencing, and how has this data changed your practice? I would love to hear from you, Jyoti, and also from you, Luda.
Sure. It's so non-controversial, right?
Right.
So let me preface this with saying that we only have snippets of data. We still don't understand like true patient journey. The world is changing very quickly, and what I know in 2024 is probably not what I'll look back, in 2026, we'll have much more data. So we're trying to figure this out in real time. And that's tough because often we're talking about sequencing therapies for patients. And so what's available, how much do you want to do up front? What do you want to think about in the second or third line settings? And so currently for patients that, as is said, for patients who are diagnosed with EGFR mutations, we can do osimertinib alone, so oral therapy that, that generally is tolerated, but has toxicity, and patients are doing it at home, but not coming into clinic as frequently. There's a combination of chemotherapy and osimertinib, FLAURA2, and now we have Mariposa, which is lazertinib, which is a drug that's a lot like osimertinib, with amivantamab, and amivantamab is a bispecific antibody that blocks EGFR as well as MET. And it's given by infusion for now. We think that there's going to be a subcutaneous version available in the not too distant future, but it's given by infusion. At first, it takes a fair bit of time to get it in safely, and then it's given once every 3 weeks. And so we know that the combination of these two drugs hit that first primary endpoint. So it improved time until progression. So it improved progression-free survival. And based on that, it was approved in the United States just last week. So a good option for our patients. But now we have much more robust follow-up. And so we've heard data from after 3 years. So really longer term outcomes. And we know that at that juncture, that it didn't have a median survival yet for people receiving dual therapy. So at 3 years, over 50% of patients we know were still alive with laser AMI, versus a median survival of about 37 months for the oral drug alone. So that's pretty impressive. It's a what we think is we would say that reduce the risk of dying from lung cancer with getting 2 drugs by about 23%. So there was that kind of a risk reduction. But that comes with issues. So we know that these drugs can be tough to take, particularly amivantamab. And the rate of discontinuation with dual therapy was much higher than with single therapy and was almost 10%. And so we're seeing that the toxicities add up, that people come off. And this sort of durability of treatment is really, you start thinking about it like, wait, you may be on getting IV infusion for 2 years with ongoing toxicity, and that may change it. And the reason I think that many of us have been like, yes, that's really great, is we know that amivantamab works really well in the second line setting as well as after chemotherapy. And so making decisions with patients now about how to prioritize, I think, is harder than ever, particularly when they're first diagnosed and the worlds have changed so quickly. Like actually being able to think about all of these different options is really difficult. Luda, thoughts on how you're using AMI laser are still similar?
Yeah, so it's another hard decision. Currently we're talking about patients who are just diagnosed with EGFR classical mutations, and you have 3 options: osimertinib, osi plus chemo, and then AMI-LAZ. And we know that both of the combination of therapies is better than osimertinib by itself, but for the price of side effects. And I personally am not seeing me using AMI-LAZ at this point, just because I think, even if you move into the subcutaneous version that will take away your infusion-related reaction, the swelling and the rash and the issues with the scalp. And I just feel like, I definitely feel that we should be discussing it with the patient. It has to be a shared decision making. And we don't have a perfect trial comparing chemo OSI versus AMI-LAZ. We're never going to have that trial. So I kind of tend to reach towards OSI plus chemo, especially for my patients who have poor prognostic factors like brain metastasis, P53 mutation, or they are ctDNA positive, because we know those patients have worse outcomes. I tend to reserve amivantamab for post-progression, just based on a toxicity profile. But again, it's a shared decision-making with the patient.
Yeah, I agree. And I think, I think exactly what Jyoti had said, that you're committing someone to essentially IV chemo every 2 weeks. And I know there's amivantamab sub-Q that's been approved, and that was on, presented at ASCO, and there was some buzz about that. But I think, in the end, it's still a quality of life issue. And I don't think we know who needs AMI versus OC in the frontline setting just yet. So, and we have to think that this is a marathon and not a sprint, right? So if you give amulozartinib, where does OC come into play? Do they even ever see it? Do they get it? And OC is still a great drug, and I'm not ready to kick it to the curb by any means. So I think more to come in this space, and toxicity you brought up is real, and toxicity from lazertinib is significant, and I don't think we know if lazertinib is better than OC, or if the CNS penetration is better, or I really struggle with this. So definitely more to come. And what about your thoughts on the Mariposa 2 data?
So Mariposa 2 is for patients whose cancer has progressed on osimertinib. They're randomized to either get chemotherapy or chemotherapy and amivantamab. And we know that triplet therapy led to better progression-free survival and significantly higher response rate. Like almost 2/3 of people had tumor shrinkage with triplet therapy compared to chemotherapy, where it's about 1/3 of patients. So certainly based on that progression-free survival outcome, I think many of us in the United States started using it as soon as it hit the NCCN guidelines and now is FDA approved. So, that's certainly encouraging, but there have been some analyses now. So the primary endpoint was progression-free survival. They'd planned on looking at overall survival. And this was sort of the second interim analysis. And unfortunately, there was really no statistically significant difference in overall survival. It was a little bit better with the combination therapy, but not so much better. We've also seen data for amivantamab after chemotherapy, and we know that that can be effective. And so now, it's really, again, talking to my patients. There's some patients that might have gotten chemotherapy with osimertinib first. If they have cancer that's progressed, I'll talk to them about whether or not we re-challenge with chemotherapy and think about giving amivantamab. There's some patients that may never have seen chemotherapy, which is still the majority of my patients who are treated with osimertinib alone. And at the time of progression, depending on how much cancer is affecting their lives, like depending on sort of the bulk of cancer, if they've got symptomatic or it's slow progression, I think it's reasonable to think about either chemotherapy and amivantamab. If we don't understand a mechanism of resistance, we've done the biopsy and there are no additional clinical trials. So it's moving around a lot. We're learning how to manage toxicities from amivantamab, but it's still tough, and those antibodies stick around in your system for a long time. We're so used in the EGFR space, oral drugs, you have some side effects, you hold it for a couple of days, things simmer down. With the antibody, it may be, weeks before you see a real improvement if you hold drug.
I I completely agree. And I think, something that scares patients and definitely is something that I really coach them about is the infusion reaction that happens, right? Because they're going from taking a pill, which is, not easy by any means, but then you're making like a mental and emotional and physical transition to getting, sitting in a chair and getting an IV infusion. And it's much more challenging. And then you tell them that, you're very likely to have an infusion reaction. And I just plant the seed that way for my patients. Because if I tell them, oh, it happens in only X amount of patients, and then they're that patient, they just get anxious. So I tell them, I would plan in your mind that this is probably going to happen. And if it doesn't happen, that's great. But if it does, I already told you it was likely going to happen. And, despite taking Singular 2 days before, despite splitting the dose into 2 days, this infusion reaction does happen and it can be very scary. And it doesn't mean that the treatment's not working. It doesn't mean that you're not going to tolerate it. It doesn't mean that it's not going to help you, but it's just your body getting adjusted to this foreign monoclonal antibody that's getting infused into your body that is foreign, right? So your body doesn't know how to react to it. So I try to tell my patients and preface that, but usually, if we're able to kind of, get you through that first reaction, it does not happen again, or I've not had it happen again for my patients. And I have seen very good responses, and we've been able to manage, the toxicity with a lot of support. But how do you, Jyoti and you, Ludo, coach your patients about this infusion reaction that very commonly happens?
I do the same thing as you, saying this is gonna happen. So just we might not even finish the day. So the amivantamab for the patients in the room, the dose for the first day is actually split in day 1 and day 2. So I never start on Thursday because usually I need a day 3. Because usually day 2 we have to stop it and like a little bit gets infused. And it's like, okay, I want to repeat the day 1. So I always start early in the week. But then just setting expectation, this is gonna happen. The good news about the infusion related reactions that they're not life-threatening. They are scary, and they delay your going home from that day, but they're not life-threatening. Another thing that we just implemented at the World Lung, there was a presentation by, I think, Dr. Pazarez, looking at different at premedications and looking at dexamethasone premedication starting 2 days before the infusion and continuing on day 1. And they saw decrease in infusion-related reaction risk, not elimination, decrease. So we actually implemented it the day after we came from World Lung. And I just gave Amy, one of my colleagues gave Amy, and I was on call. And of course, with the new dexamethasone pre-medication, and patient reacted. So like it decreases the chances of the infusion reaction, but it doesn't eliminate it. So I'm really looking forward for the subcutaneous version whenever it becomes available, because I think that will make it much easier on our patients, just because they don't take time away from the families dealing with those reactions.
The other piece, sort of the way I'll coach patients through it, is when we make the decision to do it, to really think about like, okay, this is going to be a month essentially, because you're there every week, like a month of really like all in for the cancer and managing the toxicities. And then the skin and the edema and the stomatitis, like all of those things generally really peak in those first 6 weeks, I think. And they do get better. That's the thing that we've seen. And the symptoms from the cancer get better. So there is that sort of piece like, okay, we'll see. We know that this month's going to be hard. Think about, who your caretakers or caregivers are going to be, what your support's going to be, but sort of, and having them proactively see, work with dermatology, work with our palliative care folks. Like we're kind of all hands on for those first 6 weeks, and then usually the toxicities improve over time.
Speaking of toxicity, there's a question in the chart about trying to mitigate these toxicities or sort of offset them and anticipate them with prophylactic management. Are you, Jyoti and Luda, doing anything in anticipation of development of these side effects?
So I think Luda was talking about the skipper data, and that's certainly with the dexamethasone. One piece of that is with methotrexate, which I was talking to our pharmacist today. I was like, should we do that? And again, small numbers, we're still not adding methotrexate, right? There's liver toxicity you're giving with pemetrexed. And so that piece we haven't done, but I'd love to see more prospective data. And again, hopefully I don't need it with subcutaneous soon.
But I think the Johnson & Johnson, who makes AMI, they're also investing in the prophylactic skin toxicity and prophylactic antibiotics and prophylactic other things. So we might be able to do a little bit better with the skin toxicity of the drug eventually.
Yeah, there was anecdotal data and patients that were at one point, we were looking into double dose OC for certain patients, and then concerned about, the tyrosine kinase inhibitor rash that comes along with that. And for some patients, we have a dermatologist that's very interested in this. We were starting patients on minocycline or doxycycline prophylactically to kind of offset this, and just giving them, Clinda gel on hand and hydrocortisone cream as well, saying that, you don't need to put these creams on prophylactically, but starting with like a loading dose of minocycline. I had 2 patients that we did this, and it did seem to help, especially for those on double dose OC, but I've not done this for patients that are starting Mariposa. Have you done that at all?
Not yet.
Okay. And you, Jyoti?
We do prophylactic antibiotics now.
Okay.
I come from like when we did cetuximab and afatinib. That was really hard.
Yes. Oh my gosh. Yes. So we're gonna move away from the EGFR space a little bit to talk about our final topic today, and then obviously we'll address the questions in the chat, and that's really looking at our small cell lung cancer patients, and specifically looking at sacituzumab govitecan in this setting. And I really want to hear from you, Luda, about what your thoughts are on the TROPiCS-03 data, looking at this in the second line setting for patients with small cell lung cancer. I know this space has really sort of exploded with tarlatamab, on the tails of lurbinectedin. So I would love to hear what your thoughts are about the second line space here.
Yeah, and I think this abstract probably got my silver medal at the World Lung, because we are really, really desperate in finding something for small cell lung cancer. And what they presented, TROPiCS-03 trial, it's an antibody drug conjugate against TROP2, similar to the antibody drug conjugate that Jyoti just described for Tropion Lung 01, same antibody, different chemotherapy, and similar linker. So what it does, it's a kind of a smarter bomb, as you may, what Jyoti said, chemotherapy that attaches to the surface of the cancer cell that has TROP2. It was a very small patient study, only 43 patients, but in the patients who were very heavily pretreated with small cell lung cancer, response rate or chances of a cancer shrinking was 44%, which is exciting in my opinion. And we haven't seen anything like that in small cell lung cancer. So I would like to see this drug being developed further and investigated further in treatment resistant small cell. They looked at the difference, platinum sensitive, platinum resistant disease, and responses seem to be seen in both, and as expected, platinum-sensitive disease responses were higher than platinum-resistant, but even in platinum-resistant disease, that certainly was notable. The response rate was notable for that patient population.
Yeah, I think anytime we see any response in small cell, especially in the second line setting, we're just thrilled because I would say probably 5 years ago, we really had, it was topotecan, right?
Yeah.
It was topotecan, and some people were giving irinotecan, some people Temodar off the cuff, but really there was nothing. And now we have, we have lurbinectedin, we have tarlatamab, we have all these other drugs in this space. So I guess in your practice, in your experience, when you have a patient with extensive stage small cell lung cancer that's progressing, what's your typical approach? How do you advise these patients? What tends to be your go-to?
Yeah, so for an otherwise fit patient right now, my go-to is tarlatamab, which is an approved for small cell lung cancer. It's something that's we call BiTE. This is a bispecific T-cell engager. It's a molecule that one part of the molecule attaches to the cancer cells, another attaches to the lymphocytes, and physically drugging the lymphocyte toward the cancer cell, saying, "Here, this is the cancer cell, kill it." And so that's this is a very interesting strategy. And it's a drug that has side effects, of course. They have to be hospitalized. There is some observation for a couple of days after the medication. But I think the response rate and what's important, the durability of response. So the patients who respond to tarlatamab seem to respond for a long time, much longer than what we expect with topotecan or lurbinectedin, which is our standard of care for those patient population. So that is my go-to. For patients who are not physically fit to receive treatments such as tarlatamab, then I do lurbinectedin as my second line choice.
Yeah, and I mean, I think these drugs have not been compared head to head, so it's difficult to know. Um, and I agree, underlying physical fitness is something that is really important when giving tarlatamab because you worry about cytokine release syndrome, which happens initially within the first or second infusion. And as of right now, we're still admitting our patients for day 1 and day 8, and then subsequent days we're giving in the outpatient setting, and we have a program that's looking at trying to involve our local EMS team so that we can move these patients to getting these infusions in the outpatient setting, but more to come there. Jyoti, what tends to be your approach for second line extensive stage small cell?
So mine is very similar. We've been using a lot of tarlatamab, and I just can't acknowledge like what a team effort it is. So patients, well, first we teach the caregiver like what it means that you've got to get vitals for 48 hours after the infusion, that you need to be within an hour of a hospital that can support you, to really think about what that looks like. So we administer it in clinic, and then patients are admitted to the hospital on day 1 and day 8 for that longer observation for 24 hours. And not an insignificant number of people will have the cytokine release syndrome, which gets everyone excited. You get antibodies and dexamethasone. And so certainly, that like within our hospital system, like we're just doing it at our academic medical system now. We're trying to figure out how to get it in more of the community hospitals. So again, huge burden on some patients that might have to travel to 2.5 hours to come to get treatment, stay overnight in a hotel close to the hospital rather than going home. for those initial cycles. So we're working that out. And, the company is also trying to understand, like, how can we think about using technology to monitor patients? Like, will we use wearables? Can you do hospital at home? So hopefully we'll get better at it. But I'm finding that it's going to be tough, just in terms of small cell lung cancer, unfortunately, was pretty predictable. Just it was, it's a disease for which we didn't have a lot of therapies. And now the prognostic uncertainty for someone that it may work, and it may work for a really long time. And we don't have phase 3 data yet. We're based this on phase 2. And, how patients think about, like, should I get radiation to my brain? What should I do about my other Medicaid or my other medical problems? And so it's certainly a good problem to have, but one that I think all of us are still sorting through.
But at least kind of there are now drugs for small
Yeah.
cell. I have a very extensive collection of literature, so I keep everything. And in non-small cell lung cancer, I have about 30 folders. For the EGFR resistance in small cell, I had 2 folders, limited and extensive. And I was looking at their World Doc data, like collecting my data. I have more folders. Now in small cell lung cancer, I have folders. There is like tarlatamab folder, there is like TROP2 folder, there's a B7H3 folder. So I'm happy to have folders so I can keep that information on top of my brain.
And you just brought up, like, right, there are a number of other targets we're looking at beyond DLL3, which is a target of Charla. So like SEZ6, we've got BH7, like there's a lot of stuff happening in this space. So certainly hopefully more precise therapies for patients too.
Yeah, I think we are, just as we have a deeper understanding of the histology of non-small cell lung cancer, and we're starting to kind of, I think, tap into that in the small cell space, where it sort of seemed like this completely different beast, and it certainly is, but I think we're trying to figure out how we can characterize someone with small cell lung cancer. And, is there a glimmer of someone that may have a more aggressive, phenotype as opposed to a less aggressive, and kind of trying to tap into those features. It's really exciting, and it's very rapidly developing. So cheers to more folders. I love that. But with more folders comes more complexity and sometimes more anxiety for patients, because there's more choices to make, and they're needing to make more decisions, and they're really relying on us, and they're meetings like this where we can kind of give the patients and their caregivers this information in sort of more digestible bits, and they have more time to process. Because I don't know about you, but I have 15 minutes with each patient, which
I have a little bit more.
I could cry about, because that is enough to say, hey, how are you? Let's hear a little bit about what your family life is like. But that is not nearly enough to talk about your scan, your labs, treatment options. How is that going to impact, who can pick your daughter up from school, and who can do X, Y, and Z, and how is someone going to help with this and your job? And it's insane. So I really encourage people to join these meetings and ask their questions and take the time to adjust, and don't rush into your decisions, and ask your questions and advocate for yourself. It's so important. And yes, Laura, it is ridiculous. I'm never on time, which is why I'm always 3 hours behind. So hence the reason I don't like to rush, and I don't really care. If that means that I'm giving better care, then that's just what needs to happen. So we have about 5 minutes left. So let's just take a quick look at these questions that came through, and I just want to take this time to address them. And if there are other questions, put them in the chat. We will try our best to address them going forward. So let's see. We talk about what treatments are available to manage MET amplification. And I think we talked a little bit about this, and also looking into combining treatment. So we did discuss that. We're looking at, here, this is interesting. Patients that are on, I know there's some data that says we can stop pembrolizumab if you've had a beautiful response or stable disease after 2 years, and here's someone going on 3 years and 5 months. Congratulations. I hope that you are tolerating it okay, and I hope that that you continue to have success. But I think we sort of get anxious about patients, that have to kind of come off treatment, or we have to have this discussion, or there's an opportunity to discuss. Luda and Jyoti, are you stopping patients? Are you stopping their Pembro after 2 years?
So I'm trying to personalize it. I mean, certainly I think we've seen some great aggregate data from the group at Penn showing that there was really no improvement with survival with treatment beyond 2 years. But I have anxiety about it as much as my patients do, right? And so we're trying to understand. So just as background, everyone, all the trials were done with immunotherapy for 2 years, and then it just stopped, and then it's been sort of a data-free zone since then. So one thing that I'll do if someone has had a really good response, I'll sort of set the stage, like we'll probably stop at 2 years because that's the data that we have. But usually at 2 years, what I'll do is if someone had a blood biopsy that was positive, so I was able to pick up something, like a atypical KRAS mutation in their blood, and then I know that they've had a radiographic response. Maybe at 2 years, I'll look again. So have they converted? Have they cleared the blood? And I'll probably get a PET scan. And if the PET scan's negative and the blood's negative, then I have much more confidence, because I know the data shows that for most people, if they can't, like most people will stay in remission at that time of 2 years. But if someone does have progressive disease, then the data shows that I can successfully re-challenge them and get control of disease again. And so that's sort of the paradigm that I've been doing. If someone still has evidence of active disease, then it really is joint decision making. I have a little bit more anxiety about stopping if they're tolerating well, and we'll often go beyond that. Luda, what do you guys do?
Yeah, I'm very similar to you. I have probably more anxiety than you in stopping the medication. But I do a PET scan. I don't do liquid biopsy because I just think if the PET scan is negative or minimally positive, I'm probably not going to be reassured enough with that. And if the PET scan is positive, still, I kind of, it's all again shared decision making. And I would talk to the patients. I will also take into account what's the side effect profile. If the patient is doing very well and having no toxicity, then me and my patients probably more likely to continue. My challenge is the patients who at 2 years are a true NED, meaning no evidence of disease on a PET scan. Because even though we know that if we stop it, we can re-challenge, but there is not a guarantee that re-challenge is going to be effective. There are still some percentage of patients where re-challenge is not effective. And I basically talk to the patient saying, the data is the data. We can continue if you'd like. And I kind of see the patients are separated into two categories. Some says, yes, thank you. I want to stop it. I'm done. I want to travel. And some patients like, you want to do what? I've been on this medicine for 2 years and I'm fine. The cancer is, why do you want to stop the drug? And so like, it's really, we are biased, absolutely biased. Patients are biased. Everybody's biased. So just a decision that we get to make together.
Yeah, I agree. I tend to get anxious about it as well. But sometimes it's an opportunity for a patient to just have some freedom.
Mm-hmm.
And or it's an opportunity to say, hey, we're at the 2 year mark. You've been chugging away every 3 weeks. We've been nervous about going to every 6. Maybe this is an opportunity to try that. And then that kind of is a segue to sort of stopping. But I definitely, if they had a driver that was non-actionable, I do repeat the liquid biopsy like Jyoti. I get a PET and I also get an MRI brain just for like a complete clean slate so that we know. But that's really, there's no right answer. We are at the 1 hour and 30-minute mark, which flew by. Oh my gosh, I'm so glad that we got through all the data and a little more. And I thank you both, Jyoti and Luda, for joining us today and imparting your wisdom and teaching me. I've scribbled down so much stuff. I should show you my papers here. And I really appreciate you taking time. Thank you so much.
It was a pleasure.
Thanks so much.